So in our 4 Ps, the next P we're going to talk about are the powers. And when we talk about the powers, we're talking about the force of uterine contractions and maternal efforts. And I just wanted to show you what the uterine muscle looks like. Now we have these long fibers that sort of contract and push down so that the baby's head wedges against the cervix. We have the middle layer, which really helps squeeze that baby down, and the inner layer, which is what works on the cervix to sort of pull it open. And you know, those muscles, when they're coordinated and working well, get the job done. They're a pretty good method of opening the cervix and pushing that baby down. Maternal efforts, there's a lot of discussion about whether we can let mom labor down, which is a preferred method. It saves her energy and it saves oxygen for the fetus. So really we use the uterine contractions. If mom has a good epidural and she's not feeling an urge, she can be fully dilated and not push, and the uterus will still exert enough pressure on that fetus to cause fetal descent. However, at the end, she's going to have like an unbearable urge, hopefully. I mean, sometimes with a pretty heavy epidural she won't, but there's a reflex called Ferguson's reflex, and as that baby moves into the part of the vagina where he's also going to exert rectal pressure, mom starts to feel this very strong urge to push, and it's almost like the urge to throw up. It is very involuntary. And at that point, her efforts will help facilitate that second stage of labor and get that baby to descend and emerge. And the last P in this sequence is for the psyche. And mom's emotional state does have a lot to do with labor progress. And certain things, I mean, the stress hormones that are released during labor, sometimes when mom's emotions are strong, can impede labor. Relaxation a lot of times will help facilitate labor. So some of the things that can make a labor a little less functional can be the fear, tension, pain syndrome. Now, labor's going to hurt. You're stretching your cervix. You're causing distension of the lower uterine segment. You have a lot of intense pressure down in your bottom area. Sometimes there's back pain. There's pulling on the ligaments. And so there is some pain associated with labor. However, if mom becomes afraid of that pain, and especially if she gets a lot of muscle tension, that pain will get worse and continue to get worse, and she'll release stress hormones which antagonize her body's oxytocin. And her muscles will start to contract, her uterine muscle will start to contract sort of ineffectively. You'll get lots of pain, but those contractions won't be effective. You get sort of an erratic contraction pattern. Mom's labor can also be influenced by previous birth experiences. A lot of times your second-time moms do this very well. They know that it's going to hurt, but they know that they're going to be okay. If they've had epidurals that have worked, very often they understand that there's going to be some relief for them. So a woman who's had a positive previous birth experience very often will labor well. On the other hand, a woman who's had, you know, the horrible labor where she was in labor for 2 days and nothing worked and the epidural didn't take and she ended up with a vacuum, or, you know, what have you. A person with a very negative birth experience may experience more of that fear, tension, pain syndrome. Next, we have developmental concerns. Now, your very young moms, especially your early adolescents, any mom under 15, very frequently this is a very awful experience, and sometimes these moms can have very dysfunctional labors. They can go the opposite way where their labors are very quick and almost precipitous, but a lot of times they don't understand what's happening in their body. They haven't been prepared necessarily very well by their own mothers or by other women talking about their birth experiences. A lot of times these women they get panicky and out of control. On the other hand, if you have like a mom who's a little bit older, who's used to having maybe a lot of control over things, when her body does this process that she has very little voluntary control over, she may have some issues too. So extremes of age do play in. And the next one's a big one. History of sexual abuse. And you can really see that. There is definitely a connection. A woman who's had a history of sexual abuse, when she starts to experience these sensations, especially the closer she gets to second stage when that baby descends, something just shuts down. And I do have a story of a patient. It was really, I've already told it to some of the students, but very interesting couple that came in. They wanted a midwifery birth. They had a very extensive birth plan, no episiotomy, no this, no that, no meds. Of course, she came in, she was 41 weeks, ruptured membranes for 2 days, meconium fluid, really kind of a setup for disaster. And they had this plan, it's a very elaborate birth plan that included a doula and included aromatherapy and, massage and all kinds of stuff. And they didn't want any intervention. In fact, they wanted the husband to catch the baby. And they wanted to encapsulate the placenta. There was a lot of things that they wanted for this birth. And it was, you could see where there were a lot of attempts to sort of control the process and to protect this woman from any outside interference. Well, what we didn't understand at the time was that she had a history of sexual abuse, which would explain a lot of those issues. And so she labored for, 14 hours. And every time we would get to a certain stage, the baby would sort of get a little sketchy and have a non-reassuring strip. It would definitely be considered a category 2. We didn't talk about categories with fetal monitoring, but it was not the worst, but certainly a little bit concerning. It would lose variability. We would have sort of these long variable decelerations. And we were starting to get a little nervous. Well, as we got to second stage, and Mom did end up with an epidural, despite the fact that she had been very opposed to it initially. She did end up with an epidural. She really, once the pain started, she needed to have that in order to relax. She got almost panicky to the point where we thought we were going to have to medicate her for anxiety. Once we got to second stage, we could see this real interesting sort of out-of-body experience where she would push only so far and then she would back off. Well, in the meantime, the baby was sort of crapping out. We pushed for 3 hours plus. I want to say it was maybe 3.5 hours when the midwife finally called the doctor in. And the doctor talked her into a vacuum and cut a very big episiotomy, large medial lateral. We talk about episiotomies. I'll explain the difference between the two and why we prefer sometimes a midline, despite the fact you might think it's not as ideal. So they cut this big episiotomy, and then they extended the episiotomy, and they were, trying to vacuum this baby out, and she would not push. You need to push even with the vacuum in order to expel that baby at the end. I finally took her back for a section, and the baby's heart rate was so low we had to do it under general anesthesia, so she was not even awake for the birth of her child. And the long story short is that she had a history of sexual abuse. And that sort of impacted her labor, particularly in second stage. And when the pain got to the point, or the sensations got to the point, even with the epidural, where her mind couldn't deny that sensation and she couldn't control it, it was involuntary, she sort of like just blanked out on us and really stopped participating in that birth. So that is something that really does impact labor very significantly. Another thing that can sometimes play in is an unplanned pregnancy, although to be truthful, probably there are more unplanned pregnancies than there are planned ones. If it's an unwanted pregnancy, obviously you are going to have some issues during labor. Most people have resolved that. Sorry, let me get that back up there. Culture influences birth. Every culture has, obviously, they wouldn't survive if they didn't have birthing rituals. But mostly what you want to watch in this country are women that are cut off from their culture of origin and they don't have the support of the usual people that would be around them. In many cultures, men are not in the birthing area. It is the women of the family. And if this woman is in a country, in this country, without her usual support system of, maybe her mother, her sisters, the other women in her support system, she may have a hard time progressing through labor, especially if she doesn't speak the language and she doesn't have, good support, somebody who can communicate with her easily. And even with the language line, sometimes it's hard to really form that connection with somebody if you don't speak their language. Any complications during pregnancy? If you have high anxiety, you're worried that your baby might not be okay, maybe you're on MAG, you think that something is wrong, if there's any anomalies that have been discovered on ultrasound, this may impact a person's labor as they get closer to meeting their newborn. And fertility issues, sometimes, not always, but sometimes women with fertility issues, women who've had losses, women who've had difficulty conceiving, may feel that this part of the birth experience, sometimes this is very healing for them because it's something that they can do with less intervention than getting pregnant, and sometimes it's the opposite. There's a lot of just high anxiety that there's a premium on this baby they worked so hard to get that, you know, they're afraid that things might go wrong, and maybe they have a lot invested in the perfect birth. And so those are some ways that the psyche influences labor. So moving on to what labor progress looks like, let's start with what happens before labor. Just before labor, there are certain signs that can occur that tell us that labor is getting ready to begin. Now, it's not a reliable science, and there are women who will experience these things days or even sometimes weeks before they actually deliver. But they are things that let us know that the baby's getting ready to be born and that mom's body is ready to go into labor. So one of the first things that we see, and this is typical more with your first-time moms, is lightening. And lightening is when the baby sort of drops into the pelvis. With a second-time mom, this might not happen, or might not happen until the very, very end. Might happen at some point in labor. But remember those moms that get that little bit of dyspnea or shortness of breath when they are at the end of their pregnancy because the baby is sort of pressing up to that diaphragm. They have a little less room to take a breath. Well, when lightening occurs, usually about 10 days before labor starts, that baby drops and all of a sudden it feels easier to breathe. However, it does feel a little more achy in your back. You might get more sciatic pain if you're prone to that. You might get some dependent edema. You're going to feel like you need to pee constantly, and you go to the bathroom and maybe it's, you know, tiny amounts. But you do get that urinary frequency because there's more pressure on your bladder, and you do get some more pelvic pressure and lower abdominal pressure. So that's something that can happen. Again, it can happen a couple weeks before delivery. It can happen a couple days in second time and later moms. You know, those ligaments aren't quite as springy as they were, let's say, and maybe you don't experience that lightening. Other signs that labor might be beginning. You have Braxton Hicks contractions kind of increase. And these are your false labor contractions. When you walk, the discomfort kind of goes away. They don't change the cervix. So these are the moms that come back and forth to triage. I'm having contractions, I'm having contractions, I'm having contractions. I'm 38 weeks, I'm 39 weeks. I think I'm ready to go into labor. I think I'm in labor, and you check them. And maybe they come every day for, you know, a week and a half, and their cervix hasn't changed. And those are your Braxton Hicks contractions. Again, they serve a purpose. They help sort of prepare your body for what's going to happen, and they prepare the baby for those little, it's, you know, training for a marathon. You can get vaginal show, and also people say they lose their mucus plug, but what really happens is they have an increased mucus discharge. You might also see like a, what we call like a bloody show, which is a pink tinged or blood tinged. Towards the end of labor, they get real bloody show, which is much more frank red. But you might get that vaginal show, and usually that's a sign that labor's coming sooner rather than later. That's something you would see really as the cervix gets ready to dilate. And sometimes we'll get a spontaneous rupture of membranes. Now, generally, I want to say that the water breaks somewhere in active labor, like around 7 to 8, if you let it go on its own, 7 to 8 centimeters, or when you get ready for transition. But in about 10% of women, their water will break before they even start to dilate. And that will sort of get things rolling. The prostaglandins will be released. There's more pressure from the head. But when mom's membranes rupture, she really should come in and be checked and make sure that the baby's okay. Sometimes if the baby's moving, a midwife or a doctor, if mom is low risk, might let her stay at home and wait for labor to begin. But if she's ruptured and she's CBS positive, or she's ruptured and she's laboring, she should come in. Now we get behavior changes. And the behavior changes are kind of interesting. Mom has been kind of tired all through this third semester. That progesterone's been weighing her down. The baby's taking a lot from her. And now all of a sudden, like, bam, she gets this big burst of energy and she wants to clean her house and she wants to get things ready for the baby. And she's doing laundry and she's playing with the other kids. And she gets this nesting instinct where she's got to have the house has to be ready and, you know, things have to be cleaned up. She gets a real burst of energy. She might start organizing or cleaning or getting the laundry done. And that's real common as that progesterone drops and mom gets a little bit more energetic. So that's, you know, one of the behavior changes that happens just before labor. And then you get the GI symptoms. You get sometimes a little diarrhea. Again, your progesterone's dropping, so that hormone that was sort of slowing down your gastric and peristaltic motility, that hormone drops, and now you might get a little diarrhea, you might have some indigestion. Some moms even lose a little bit of weight, you know, a pound or two right before labor begins. But these are some of the signs that precede labor. Now, again, they don't happen to all women, and they don't happen in every pregnancy. So they're less reliable, but they are common. So those are some things that you might teach mom to expect as labor gets closer. Okay, so now once we get into real labor, we have some stages of labor. We have the first stage, which is all about the cervix. We're going to talk later about the second stage, which is about descent and pushing out the baby. We have third stage, which is the placenta, and we have the fourth stage, which is bonding. And we'll start at the beginning and talk about the first stage, all about the cervix. The cervix needs to undergo a lot of change. I'm going to show you dilatation, because that's one of the ways that we measure labor progress. And this is a chart of cervical dilatation, and this is the opening of the cervix. Now, the cervix has to go basically from a closed structure that you see in this picture here all the way to 10 centimeters. Now, if you look at a ruler or something that has 10 centimeters, it's about 4 inches, okay? And that is enough to sort of let the baby stretch their heads out. But that's complete dilatation. When you do an exam on a patient, what you will find, when you call it 10, what you're really feeling is no cervix at all. You're feeling nothing but the presenting part. But the first stage of labor is where the cervix goes from 0 to fully dilated, to 10 centimeters. Okay? There are other changes that the cervix has to undergo. We already talked about dilatation. Now we talk about effacement. And when we get to class, I'm going to show you, I'm going to bring in some different size rubber bands. Effacement is the thinning of the cervix. And here's a good picture of effacement. And you can see in the first picture, let me point that out for you. Hold on, I'm going to change colors with my arrow so you can see it better. But here is a cervix that has no effacement. It is long, thick, and closed. That would be how we describe it. So it's 0%. Okay, and when you feel that cervix, it's going to also probably feel hard. That's another change. Cervix will get softer. But effacement is the thinning. So notice the difference in the length, this cervix to this cervix. So this cervix is 50% effaced, which means that labor is, if it hasn't begun, it's probably going to begin soon. And then you have 100% effacement. Now, the significance of effacement is that, I don't know if you guys have ever felt the difference between like a rubber band that goes around broccoli, let's say, that real thick, stiff rubber band. That's what a cervix that doesn't have a lot of effacement feels like. It feels like it's hard to stretch. You have to really put some effort into getting it to open. Whereas say if you have like a rubber band that's a little bit thinner, a lot thinner, okay, and you can really stretch it out as far as you can and snaps right back. So as the cervix is effaced, it becomes easier for it to dilate. So a lot of times that's the first change we'll see. And when we try to induce labor, that will be the first change that we try to induce is cervical effacement. If we can get it to be thinner before we start medicine to contract, to make contractions happen, those contractions will be much, much more effective because they won't be meeting such resistance. So that is effacement. Another change that the cervix is going to undergo is, we call it ripening, but it's going to get softer. And you're going to feel that. It's, you know, in the beginning, it'll feel sort of like you won't be able to indent the cervix with your fingers. I'll put it that way. It feels almost like your gums. It's kind of hard tissue. Whereas when labor starts to begin, it will start to feel really soft. You'll be able to feel like the tissue on the tip of your lips or on the tip of your nose. It'll get a lot softer. We call it riper. And you can feel the difference between somebody who is really, whose cervix is really soft. The other thing that it will do is it's going to move from the posterior to the anterior position. And that is another good way to gauge how the cervix is changing. So when people do a cervical check or a exam during labor, an exam, they're generally going to notate it in terms of dilatation, effacement, and then they'll talk about station. So let's say that we examine mom in the first stage of labor, and we find that she's 3 centimeters and 50% dilated. We'll do it as 350, and then let's say she's at -1 station, which was something we talked about with the passenger. That's how they're going to notate that. So 350 and -1. And that's a really easy system to remember how far mom is. And when I look at that, I get a feeling that mom is in the latent phase, getting ready to go into the active phase of labor. And that's the next thing that we're going to talk about. Okay, now the first stage is broken into 3 phases. Do not get them confused. First stage is all about cervical change. Second stage is all about expulsion of the fetus. Third stage is the placenta. Fourth stage is bonding. But the phases of the first stage of labor kind of characterize that first stage, what happens during cervical change. And we start in a latent phase. And this is the longest phase there is. And I said 1 to 3, but let me change that. It's going to go most times from 0 to 3. 0 to 3 centimeters. And your effacement is going to go from that thick cervix to about 40, maybe 50% effaced. Okay? Still have a ways to go. We have these mild irregular contractions that become gradually more regular and more frequent. They start out maybe 10 minutes apart. Maybe you get one that's 20 minutes, maybe one that's 5. They're irregular. They are mild to palpation. Okay? Let's take a little detour and talk about what a mild contraction feels like to the examiner, because you can't always gauge by mom's reaction. Sometimes mom is vocal about her pain. Sometimes she's not. And that's not a good way to judge the strength of your contractions, okay? And we'd already talked about how electronic fetal monitoring, if it's external, won't tell you that. No matter how big those little hills are, you're not going to know how intense your contractions are unless you actually palpate mom's belly. Now, mild contraction feels like the tip of your nose. That's how far you can indent that uterus, okay? When you put your fingertips on the fundus. Now, of course, mom's not going to like this too much, but you have to do it sometimes. You just say, I need to feel your belly, and very gently press down. You're going to see how far you can indent that uterus. If it feels like the tip of your nose, that's a mild contraction. Now, that doesn't mean that mom's not experiencing pain. It just means that contraction is not as forceful as it's going to get. Now, a moderate contraction, a contraction of moderate intensity, is going to feel like your chin. So reach up and kind of feel your chin. There's a little bit of sponginess there, but it's harder to indent. Okay, so that's what a moderate contraction feels like. Feels like you're pressing on your chin when you're pressing on mom's belly. And you'll start to get a feel. If you do enough of this, you will start to feel, even your heavier moms versus your thinner moms, you'll know it's a little tougher with the really big moms, but you'll start to feel what feels like mild to you, what feels like moderate, and what feels like strong. Strong feels like your forehead. So if you reach up and kind of try and press on your forehead, you feel how much stronger that is towards the end of labor as labor progresses. That is what a strong contraction is going to feel like. So now you know. Talk about palpation, and palpation is very important. In the latent phase, you're going to feel more like the tip of your nose. Okay, mild contractions. They are irregular. Mom's behavior at this point, as much as she might be like, oh yeah, that was really painful, or that hurt, and wow, that was a strong one, she's talkative, she's happy, she's excited, she's on Facebook, she's telling everyone, I'm in labor, finally. This mom, the real active labor hasn't hit her yet. And so for this mom, you're going to, let her walk around. It's not always good to have them in the hospital too soon if this is a spontaneous labor. At this point, mom is actually, most of the time, unless she's got risk factors, better off at home. People labor better in their houses. They get up, they watch a little TV, they've got their comfy couch, they're not strapped to a bed with a fetal monitor on. And unless they have risk factors, there's really no need for that. So a lot of times, yeah, you're in labor, but we're not going to keep you because you don't need medications or interventions at this point. Just go home and wait for your labor to get more active and then come back when your contractions are closer together and you can't talk through them. Generally speaking, you can do some telephone triage. It's not the most reliable method, but if you're on the phone with somebody and they talk in full sentences right through a contraction, that's still latent phase. Okay, so they may be in labor or they may not be in labor, but until they have to stop talking when that contraction comes, they're still early in the game. It's a latent phase. The cervix is changing, but very slowly. So let's talk about how long this can take. The average length for the first timers is 8.6 hours to get from 0 to 3. That is an average. I can tell you that there are women who do it, even first-time moms who do it much quicker, but there are moms who take a lot longer. There are moms who can spend a day or two in this latent phase, and they're the ones that will tell you, oh, I was in labor for 3 days. But the first 2 or 3 days of their labor maybe was some of this, where they were able to get up and eat a sandwich, or, they could watch a movie and understand the plot, or they could talk to people on the phone, or they could update their Facebook page. You spend a lot of time in latent phase for a first-time mom. Your multip's about 5.3 hours. This is the hardest phase to predict. I mean, you are really trying to change a cervix that wanted to stay pregnant into one that's going to let a baby out. So it does take a long time to get from 0 to 3. And as I said, if mom doesn't have risk factors, she can do a lot of this laboring at home. But that is the latent phase of the first stage. And the next thing we're going to talk about is active phase of labor. We're still in the first stage. Okay, and at this point, let's make that a little bit bigger. The cervix is dilated 4 to 7 centimeters. Contractions are usually regular, and we can be from 2 to 5 minutes apart. They last at least 60 seconds. They can last longer, sometimes 90. And they're moderate to strong intensity, and that gradually progresses as well. Okay, so let's talk about how mom responds to this. Most moms now get very serious. Sorry. They need to focus. When that contraction happens, they do not want to talk to you. They do not care about their Facebook page. They don't care how their hair looks or their makeup. All they care about is getting through that pain. Mom is progressively effacing. Her baby is getting lower. She's getting more tired. She may have trouble coping with the pain. Generally, this is where most moms will start to ask for their epidural. You'll get moms that ask for it earlier, trust me, but at 4 to 7, that is when most moms say, that's it, I'm done, I can't do this anymore. And this might be, if the mom is a good candidate for an epidural, this is a really good time to get one. She'll get her money's worth out of it. I mean, I'm just being facetious really, but, she'll get some time to relax. She might be able to sleep. If she's not planning on an epidural, this is when she needs intense labor support. This is when her partner needs to sort of step up and you need to assist, maybe we need things like the jacuzzi or the birthing ball. Maybe we need to focus on breathing or distraction or massage or heat or cold, all of those labor support techniques. Earlier than that, if you start breaking out all these strategies, a lot of times what's going to happen is now mom's sort of bored with them. They have a shelf life and she can't cope and she gets this active phase. So, you know, when active phase hits, that's when you really want to step up your labor support. The average length for this stage is about 4 or 5 hours for your first-time moms and about 2.5 hours for your multips. So this is a relatively short stage, and the rule of thumb is about 1 centimeter per hour, a little longer for your first-timers and a little less for your second and third-timers, and you know, anybody who's given birth more than that. Your mileage may vary. Every labor is different. You can be a first-time mom and do this in an hour or two. You can be a second-time mom and it takes you a lot longer. But that is the active phase of labor. And like I said, this is where most of your labor support interventions, including pain medications and epidural anesthesia, are going to take place. Now, the last part of the first stage, still in the first stage, still talking about cervical dilation and change, okay, is transition. And transition is the hardest phase to cope with. Thankfully, it is the shortest phase to cope with. The cervix at this point is 8 to 10 centimeters, and this is where even a mom who's been coping very, very well, using her normal methods, will start to feel like, I can't do this anymore. Now, these contractions are at least every 2 to 3 minutes. They are strong to palpation, and they can last about 60 to 90 seconds. And trust me when I tell you, it is the longest 60 to 90 seconds of your life. You guys had trouble with the clothespin, I think, when we did this in fundamentals. This is the phase where people start shaking. You'll see an increased bloody show. When I see transition signs, I get excited because I know that mom's almost done. But she's not excited, and her partner's not excited. Partner or her support team is usually very, like, upset. They're more upset than the mom sometimes. Do something, help. So you'll see all this shaking, nausea, vomiting, irritability. This is when mom tells the partner, get away, don't touch me. A lot of times they don't want to be touched, or they're sensitive to light, or they're sensitive to sound, or they're sensitive to smells. It was always a funny thing. You get the support people, and they'll go, she's throwing up, she's nauseous, and you walk in the room, and they're eating pizza and hot wings. You're like, oh boy, get rid of that. Because mom at this point will tell people, I don't want you here. Stop breathing on me. Stop talking to me. Everyone be quiet. They get very short-tempered because they can't cope. The other thing about transition is that mom may have the urge to push before she's fully dilated. And this is sort of one of those if this, then that kind of things. Generally, we like mom to wait until she's fully dilated to push. However, and your first timers definitely, you don't want them pushing against a cervix that's never opened all the way before they're fully dilated. However, sometimes you'll get a multip, and they have that kind of stretchy, like a worn out rubber band kind of cervix. And you can feel that when you examine them, and maybe it's just a lip or a rim. You only feel it on one side. Sometimes they can push right through that. But very often we don't want them to push until they're fully dilated. So what we'll tell them to do is sort of blow or pant. I tell them it's like blowing out candles. And I kind of breathe with them a little bit to sort of get them through that. Now, a lot of times this will only last like a couple of contractions. But your transition phase, in a mom who has an epidural, they're not going to experience all this stuff. They may have some shaking and be like, wow, I feel really shaky. And they'll feel a lot of pressure. They'll feel pressure in their bottom. And some women tolerate this because it's not really sharp pain. And other women will be like, I can't take it. I can't take it. It hurts. And you'll say, well, what are you feeling? And you can even, test their level of anesthesia with like a blunt needle. and they won't feel you poking. They'll have a good level of anesthesia, but that pressure sensation is so intense for them that they interpret it as pain. And so you might, even with an epidural, have to coach mom through a few of these. The average length of transition is very short. It's really about 20 to 40 minutes on average, but you'll get moms, the first timers obviously take longer for everything, about a half an hour. It can be up to 2 hours for them, but hopefully not. Your second timers can go through transition in like 2 contractions and be done and be ready to deliver. So this is the shortest phase. Now, if first stage of labor is concerned with the dilatation and effacement of the cervix, so that the cervix is out of the baby's way, second stage is all about descent and delivery. This is the pushing phase. Now, in regards to that, there are 2 methods that facilitate descent. We have passive descent. And this is where the force of the contractions move the baby down. Okay? And then we have mom's expulsive efforts when mom pushes. Okay, now the literature is really talking a lot about the use of passive descent. We call it laboring down. And for a mom who is fully dilated but feels no urge to push because the baby is still pretty high in the pelvis, laboring down is great. It prolongs second stage because it's going to take the uterus a lot longer to work without mom's help. However, the actual pushing time is reduced, which is pretty important because when mom pushes and holds her breath, there's less oxygen going to the baby and mom gets tired. Okay, so laboring down can be really helpful, and maybe she's complete now for 4 hours instead of 2 hours, but she only spends 45 minutes of that actually pushing or less. So passive descent can be a reasonably good way to handle second stage, or most of second stage. As long as the baby looks good on the monitor, there's no need to rush mom into pushing. Pushing will speed things up, but they'll also stress your baby out and get mom tired. In order to facilitate laboring down, we can use positioning. And when we talk about positioning, remember the labor support lab, I showed you some pictures of peanut balls. Let me see if I can get some of them up. Okay, so here you see the use of a peanut ball. If mom has an epidural and she can't stand or squat or do any of the things that use gravity in an active way, we can help her by positioning her in high Fowlers, which uses gravity to assist descent. And we use this peanut ball to really open up the pelvis. And there's a couple of different ways you can use it. But here you see we have one leg that's sort of on the bottom, and the other leg sits in that groove in the peanut ball and kind of hangs open a little bit. And that keeps the pelvis open, and mom's positioning in high Fowlers will assist descent. And so that's one way that we can support that laboring down process. Now, another way that we can facilitate descent without getting mom to push just yet is to keep her bladder empty. So we may need to straight cath mom, or some docs may actually already write the order for Foley catheter if mom's getting an epidural at, say, 4 centimeters. We don't know how long it's going to take her to labor down that baby. So catheterization or use of a bedpan in a mom who can void voluntarily is a good way to keep that bladder empty so that we're not delaying the descent of that baby. Let's see if I can move some of these down a little bit. Okay, and so that is passive descent. We're going to talk a little bit more now about active methods of helping that baby to descend, and that's when we talk about pushing. The best evidence-based practice now talks about open glottis pushing. Now, mom will involuntarily start to push if she's not medicated when that fetal head reaches a certain point and presses on the, she'll feel rectal pressure. it's sort of like vomiting. You get a certain urge and you can't really control it, and that reflex is called Ferguson's reflex. You don't need to know that necessarily, but that's just what it's called. Open glottis pushing means that mom might vocalize, and that usually it's not a scream, it's more of a like a moan or a grunting, but we want her not to hold her breath. Open glottis pushing means that she can't hold her breath. The forced, we called it purple pushing back in the day, and you'll still hear doctors tell their patients, hold your breath for a count of 10. And really, if mom doesn't have a strong urge to push, that is sort of an easy way to get her to remember how to push. However, when mom holds her breath for a count of 10, and she does that 3 times in a row and holds her breath really for almost a full minute, all said and done, your baby's going to get tired, your mom's going to get tired, and the outcomes are not necessarily better. I don't know the statistics on how much time you save by using those techniques. I do not think that there is a significant difference in the length of time. I do think that there is better perfusion to the baby when you have open glottis pushing. And a lot of your strips will start to look kind of ugly in second stage, but more so when you have that forced breath holding. Okay, so how do we know that second stage is about to begin? Well, we start to see the bulging of the perineum. If mom's not complaining of pressure already, if she's got that good epidural, you might see the perineum bulging with the contractions. So we're going to see the patient's going to complain. They feel like they have to have a bowel movement. May complain of unbearable pressure. That patient might have some passage of stool. Or flatus. As the baby's head sort of pushes everything down with it. And at the very end, you're going to get the rectal mucosa will sort of turn inside out. Like the anus sort of everts a little bit. So you'll see that. Again, at the very end, we'll have crowning. And I'll get you a nice picture of that. And mom will report stretching and burning at the bitter end. That's called a ring of fire. And you can feel this even through an epidural, depending on the epidural. A lot of times they're better at contraction pain than they are at taking away that pain at the end. So those are some things that tell you that delivery is more or less imminent. Sometimes the patient will complain of that sensation before the baby's really come down too far, and sometimes before they have full dilatation. But these are the signs that tell you that delivery is coming and coming soon. And I'm going to find you a picture of crowning. Give me 1 second. Okay, and so you see what crowning looks like. And crowning usually gets followed by the birth of the head. When that happens, whoever's attending that delivery, the doctor or the midwife, and sometimes the nurse, things happen quickly sometimes, feels for that nuchal cord. And here I have a picture of the head emerging, and there's a practitioner. He's got a Kelly, and there seems to be a nuchal cord. He must be cutting it. And there's 2 ways of dealing with a nuchal cord. You can either reduce it by slipping it over the baby's head, or you can clamp it and cut it. If you can slip it over the baby's head, that is generally the better way to deal with that, because now once you've cut the cord, you've cut the baby's blood supply off. If you have to do it to get them out, you do it, but you kind of hope the shoulders don't get stuck. Now, once the baby's head's delivered, the shoulders usually come out pretty quickly. If they don't, we have an emergency, which we'll deal with in the last part of this unit, called shoulder dystocia. But usually the baby's body comes out with one push, and that's almost like involuntary every time. Once the head's out, the rest of it comes pretty simply. So that's really how second stage works. Now, sometimes we might need to get that baby out a little bit quicker. We might do something called an episiotomy. And this is a little incision into the perineum. I'm going to get you a picture of that. Okay, and here we have both types of episiotomies. There is a midline episiotomy, which is here. It's that straight line that goes up and down, and there's the medial-lateral. Now, there are advantages and disadvantages to both. And to be perfectly honest, there's been a movement towards fewer episiotomies in the last, I want to say, 20 years or so. When I was in nursing school, I was told by my instructor that if you don't cut an episiotomy in a first-time mom, she'll tear so badly you'll never be able to repair it correctly. Well, that was the popular thinking, that episiotomies were pretty standard. And then they studied it, and I remember taking a class where they talked about the results of that study, and what they found were that women who had spontaneous lacerations actually healed much, much better and faster than women who had episiotomies. And that episiotomies, both types, can extend, and they're automatically, because you cut the muscle, you're automatically a third-degree laceration, and we'll kind of talk about the degrees. But the two types that we have the midline. The advantage of the midline is that it cuts the body in a place where those muscles want to reattach and heal. Now, I know you've probably looked at it and think, well, it could extend into the rectum, and yes, it can sometimes do that. Hopefully, if all you need is a little bit of room, that won't happen. But it is common to tear. It is not common to have a fourth degree, which is a tear that extends all the way through the rectal sphincter, even with a midline episiotomy. Generally, you only need a little bit of extra room. And the cut that they make is really small, and when that perineum is completely stretched out for a birth, and those of you who come to the hospital and see a birth, you'll see that there is room for that little incision that's maybe about 1 centimeter in length. The medial-lateral, the advantage to that is that you can make it larger if you have to, and it will not extend into the rectum, although the way that you cut the muscles makes it much more difficult to heal from, and these are the moms that need constant ice and support, and they need Percolone all the time. It's a very, very painful recovery with a medial-lateral incision. Thankfully, we don't do as many episiotomies. You'll see them more when we do, like your operative vaginal deliveries, your vacuums. Sorry, I keep making things disappear. You'll see them more with that. So you can have also greater blood loss with the medial-lateral because of the way the blood vessels are. Okay, so when we talk about episiotomy, I know you had a lab and we talked a lot about that. What is more common is a laceration. You'll get lacerations of the perineum. And a first degree, second degree is pretty common. You can have women who deliver with intact perineums. The size of the baby does make a difference, but it's also the mom's tissues, whether or not they stretch, if they have elasticity. And it's the angle the baby comes down at, and whether or not they have what's called compound presentation, which is a hand that kind of comes along with the head. But it's an injury to the perineum as a result of birth. Okay, and they come in degrees. You have a first degree, and that is your perineal skin. I don't know why it keeps defaulting to things I don't want. And a little bit of the vaginal mucosa. Okay? You can even have an injury that just results in injury to the skin, and that is, we used to call them like skid marks. We still call them that. But a first degree is not very extensive. It's skin. It's very superficial. And a lot of times they'll stitch it, but every once in a while they don't. You can have a second degree. Laceration, and then you have skin, vaginal mucosa, and the, fascia. That can be what's injured in a second degree laceration, okay? And that's always repaired. But it's usually not a terrible laceration to recover from. We give mom basic comfort measures. Usually they're not in repair for a very long time. So that's your second degree laceration. Now you have your third degree. I don't have good pictures of these, by the way, and I don't think you probably want to see them anyhow. A third degree extends to the muscle. So we have skin, vaginal mucosa, fascia, and muscle. And it approaches that sphincter. Doesn't go all the way through. Let's move these up. But it goes into the muscle. Third degree are a little bit more difficult, and a lot of times if you have a third degree laceration, the provider will sort of make sure that there's no communication between the vaginal mucosa and the rectum. If you have that, that's called a fourth degree. And this is where, you know what, let me sort of move some of these other things. Put that there. Sorry, I just need to make a little room. Give me a sec. But your fourth degree. You have skin, mucosa, muscle. You go through the rectal sphincter. And you expose the lumen, the rectal lumen. These are horrible. And the repair for them looks awful, just so you know. It is no fun at all. They actually have to use instruments that look almost like medieval. They're barbaric. You see fourth degree more with your forceps deliveries and sometimes your vacuums. It has to be a physician who repairs this, and I've even seen them take people back to the OR for repair for this because it is so extensive. They want to make sure that they get it right. If this isn't repaired correctly, mom will have problems with sometimes fecal continence, also bladder incontinence. So it's really important to do these. Now, they're not common. When they happen, the mom should know that, yeah, you had a very extensive repair. You need to have, a diet with lots of fluids. You want stool softeners. You want to make sure that her first bowel movements are not painful to her because she will have extensive pain with this. You might want to instruct her that when she gets up from the bed or from a chair that she should squeeze her buttocks together to sort of splint that. It's really almost like a surgical incision, but that is a fourth degree laceration. So next we move on to the third stage of labor, which is all about the placenta. So let's kind of make a notation there. This is all about the placenta. It begins with the delivery of the baby, okay? And it is complete when the placenta delivers intact, hopefully. And so the signs that we're getting ready to deliver the placenta, you usually get, with the placenta separating, you get a firmly contracting fundus. It'll kind of look like a globe, and it'll sort of hit between the symphysis pubis and the umbilicus. So the fundus will start to really, really contract, really clamp down on that placenta and try and get it out. I'm just trying to make things look even. So you get that firmly contracting fundus. On top of that, you get a gush of blood. So that's another sign. And it's usually dark blood, and then the umbilical cord looks like it's getting longer because the placenta is coming out. So like a sudden lengthening of the umbilical cord. Now at this point, usually the cord has been clamped and cut. Some practitioners will leave the cord attached until it stops pulsating, and you won't get delivery of the placenta until that happens. So that's the third stage. And then the fourth stage is all about bonding, which is something you're really going to hear more about. It's the immediate recovery period. So let's I'll just tell you about fourth stage real quick. There's not much to it because then you go into new content, which is postpartum. But the fourth stage of labor is the immediate postpartum recovery period. This is where we watch mom for signs and symptoms of bleeding. There we go. Okay. We worry about the uterus contracting, so we want the uterus to start the process of involution. We want to make sure mom's vitals are stable. A lot of times during pushing, mom's heart rate goes way up in like the 120s, 130s. It almost mirrors babies. When she delivers, it should all go back to normal. Her blood pressure may go up. That should go back to normal. And we see bonding. I told you it was all about bonding and attachment. Best thing for mom and baby at this point, if you can manage it, if there are no issues, is to put them skin to skin. Does wonderful things for mom and baby. It sort of sends out a lot of those chemical, hormonal signals to the body to send out more oxytocin. That oxytocin that helped that uterus contract during labor is now secreted in copious, massive amounts, and we're usually flooding them with it exogenous oxytocin as well to get that uterus to clamp down and contract and keep them from bleeding. And then we're going to try and initiate breastfeeding, which also does great things for mom's body and for baby. And that first 2 hours is almost like a golden period for mom and baby. Baby is built to sort of attach. They have a lot of that quiet, alert time, and they're staring intensely at mom. And their little brains are sort of made so that they prefer faces to anything else. They like the contrast. Particularly, they go for the eyes. And so they will maintain eye contact with mom for so long. It's just a beautiful thing. But all of this does good things for them psychosocially. It also does good things for baby physically. It helps them regulate a lot of their body systems when they're skin to skin and attaching to mom. And it helps mom's body kind of go back to normal because that oxytocin that's released with those bonding behaviors is also going to work on her body to help her contract her uterus, to keep her from bleeding. It's also going to help her sort of be able to initiate breastfeeding a little bit easier. So that is the fourth stage of labor. And now we're going to talk about the interventions that we can do at the various stages of labor. Okay, so our care of the woman in labor is going to depend somewhat on the stage of labor that she's in, what her underlying conditions are, and, to some extent what the doctor has ordered. But interventions will start at the beginning for the latent phase of the first stage of labor. Okay, we're going to encourage rest. As I said, moms labor better at home, but if they're in the hospital, try not to let her get too worn out, and encourage distractions. These are the moms who could play cards with their husband in between contractions, even during contractions sometimes. We might have them watch TV, whatever. They might be allowed to eat and drink lightly, unless there is some reason. If they're a previous cesarean, we might not want them eating or drinking, and they might be, clear liquids or ice chips. If they're in the hospital, we're going to do vital signs. Per your policy, it could be every 4, it could be every 2. If they're ruptured membranes and they're not in labor, they're still going to get a temp every 2. But their blood pressure, that might be, it's determined by your policy. It could be, every 4 hours, it could be every 2 hours. Some places, if you're in the hospital in labor, it's every hour. But that seems excessive. If they could be doing this at home, there doesn't seem to be a reason to bother them that much. Okay, so when the patient comes in, you're going to notify, provider that they're there. Go through their prenatals. Sorry, the spell correct is crazy. Make sure that they, you know what their GBS status is, because if their GBS, this is group beta strep, and we'll talk about that separately as a risk factor. Group beta strep is a bacteria. We may have talked about it a little bit in antepartum, but it's normal flora for a lot of women. It's not necessarily an infection. It doesn't cause symptoms, but babies can get a GBS infection. So we need to know mom's GBS status, because if she is GBS positive, she needs to be treated in labor, preferably with penicillin. If not, hopefully they did a culture and sensitivity on this organism to find out what it was susceptible to. Could be Clinda, could be Vanco, could be other agents. But you're going to know that. You might draw some labs and maybe start a HEP lock. Remember, we talked about intrauterine fetal resuscitation. If you're going to have this mom on the monitor, you might want to have an IV access just so that you can bolus her if you need to. But do you see why it's kind of better if they stay home until they're really in a good, active, rolling labor pattern? But this is, all dependent on a doctor's order. Anyway, we're also going to monitor that baby. It could be continuous or intermittent. But if they're in the hospital, we're going to want to know what that baby's doing. It's part of our job. And like I said, if it's latent, there's no reason to torture them, maybe making them lay in bed. They should be allowed to get up and walk around and burn off some of that energy. But you don't want them to necessarily be, for every mild contraction, sitting on the ball, using complicated breathing patterns, getting in every single position that they read about. At this point, you really want them to conserve some energy. Walking is fine, playing cards, watching TV, those kind of interventions. And like I said, this is the mom who's going to cooperate with all of that. But you do get some moms, I feel like they waited so long for labor that once they have a few contractions, they feel like they need to try the jacuzzi, and they need to do the birthing ball, and then they need to do some kind of yoga. And it gets to the point where then they hit the real active phase of labor, and now they have no coping skills that really work for them. Okay, so during the active phase, this is the point where a lot of people are admitted to the hospital. So we're going to do vital signs. And here it could be hourly or every 2 hours. You don't want it to go that long. You want to know what mom's doing, because labor's a stress for mom and baby. You're going to have fetal monitoring. In an active phase of labor, you're going to want at least. You can do intermittent. Most people at this point are continuous. It just sort of depends on what the culture is at your institution and what mom's risk factors are. If she's low risk, she can have intermittent, but at least every 30 minutes, you're going to have to get a fetal heart rate, and you're going to have to palpate contractions, or put her on a fetal monitor and monitor them that way. You would want to, when you're getting that check every 30 minutes, you need to leave it on through a contraction and at least 30 seconds after, to make sure you're not having lates, you're not having variables. You want to see what that baby's really doing. And I usually, if I'm only doing this every 15 or 30 minutes, I'm getting a good, couple of minutes there, 2 or 3 minute check. Okay, so that every 30 minutes is good for low risk. If they're high risk, now your book might say that they can have every 15-minute monitoring, but usually those people are not candidates. They could be on continuous, and then you would have to document every 15 minutes. Now there's a lot of people, if you have electronic fetal monitoring that captures a record, you might not have to chart every 15, but you need to continuously monitor that patient then. And during the active phase, this is when labor support becomes really important. This is when you want to break out everything you have. If you have heat, if you have cold, if walking helps, if position changes, if you want to get mom has back labor, get her on hands and knees or have her leaning over something, get her leaning over the ball. If you want to put her in the jacuzzi or if you want to get her in the shower. This is where she really needs you to help her learn how to cope. And in the beginning, what you're really going to do when she starts getting serious is you're going to educate her and educate her partner and give them some strategies. And that way, if you can't be continuously in the room, and sometimes you can't. I had 2 patients last weekend, and there was no way that I could be in both rooms at the same time. And they weren't ready for epidurals. But you can teach them some coping strategies if they haven't been to classes, and you can teach the partner. It's really important to help the partner feel empowered to help this woman through her labor. If he or she, if it's the patient's mom, isn't empowered to do that and they start to panic, they're not going to be much comfort to this mom who is doing something that that may be the hardest thing she's done in her life. So labor support and pain management. This is maybe where you're going to give either narcotic medications or the epidural. You're not going to give the epidural, obviously, but you are going to assist with that process, and you're going to be the person who initiates, who tells providers that this woman is requesting an epidural. Okay. Usually at this point, mom is clear liquids or ice chips, but you want her to stay a little bit hydrated. She's probably going to have IV fluid at this point, but you want her to drink or have the ice chips if that's all she can have. Encourage voiding. We already talked, if she has an epidural, you want to empty that bladder. She may not be able to empty it herself. Okay, and one more thing that you're going to do for this mom and baby is that if her water breaks, you're going to document that. You're going to document the color, whether it's got meconium or it's clear. If it has meconium, you might want to describe that meconium in terms of thickness, whether it's thick meconium or thin. It can look like pea soup, or it can look like just a greenish tinged fluid. So you want to document that, and you want to document any foul odor. Obviously, once her membranes rupture, she's got to have a temperature every 2 hours, and we're going to minimize vaginal exams to minimize the chances of infection. If you do a vaginal exam, or if a provider does, you're going to document the finding so that we have some record of labor progress. So those are the things that you're going to do for people during the active phase. Obviously, if there are findings on the fetal monitoring strip that are variations, they're not normal, you're going to act on those. You're going to give intrauterine fetal resuscitation, or you might have to, give SBAR to your provider to come and see that patient to make a decision. Okay, so the next phase that we're going to talk about is the transition phase, and how we take care of a woman during that part of labor. Obviously, you're going to support the patient and the family through the contractions. This is the part that most people have trouble coping with. If you let the patient and the family know that this is really intense, but that it is very short-lived and pretty soon they'll be holding the baby, you tend to get a little bit less of that high emotion. Comfort measures, position changes, whatever feels good to mom. Just remember that at some point she may not want to be touched, she may not want to be talked to, she may want to be left alone, or she may want you to not leave the room. And you kind of have to leave that up to her. Now, at this point, if you know that delivery is coming, you need to really let your charge nurse know, so that if you were caring for another laboring patient, they can reassign that person and you can be more one-on-one with this person. So things like massage might have been really comforting at 7 centimeters, maybe at 9 centimeters, this mom doesn't want to be touched, but she's really not ready to be left alone. You see my note, toilet with caution. Mom will say, I need to go to the bathroom, and she'll, maybe feel more comfortable in that seated position, but be very careful. If mom starts to feel any pressure at all, make sure that you check her. We have had at least one baby that I know of born in the toilet, and it was not fun. Not my patient, thank goodness, but it does happen. At this point, you may need to do some vaginal exams if mom will let you, to determine when mom is ready to push. But you're also going to listen to mom as you're monitoring vital signs and looking at your fetal heart tracing. You're going to listen for a change in the way mom sounds. She might go from this moaning and panicky voice to this low, guttural, sort of grunty vocalization. And that lets you know that the baby is lower down and she may be fully dilated and ready to push. Also at this point, you're going to get your room ready. You're going to set up your warmer, make sure that your delivery table with all the instruments is set. And you're going to make sure that your provider knows that you're getting close to delivery, especially if they're not in-house, if they're out, if they're home or at the office. You want to make sure that they know they need to make their way in. If it's a multip, I usually call them around 5-6 centimeters when she starts getting active, because really at that point, you're counting down to delivery. If it's a primate, I let them know at about 8. I don't make them come in necessarily. I just let them know. I update them on the status. But definitely, once you get to transition, once you start getting to 8 centimeters, they need to know that mom is getting ready to have a baby. Okay, so during second stage labor, our role changes. And at this point, we are one-on-one. We don't leave the room if mom is pushing. If she's laboring down and not pushing, then we just kind of monitor. We can monitor that from the desk if we have to, and keep an eye on her fetal heart tones, and but check frequently in the room. As soon as mom starts to actually push, we don't leave her alone. We continue to monitor fetal heart tones. And at this point, a lot of your strips might go from that very reassuring strip that we love to look at, that moderate variability and accels and normal baseline, to something that's a little less reassuring. You might see deeper variables, you might see a loss of variability, but if we're at the end and making good progress, this is something we watch, and hopefully we can recover. If the baby's heart really looks, pretty bad, we can do some interventions to try and normalize this process and still affect a delivery. We might have mom push with every other contraction, or push on her left side. Things like that. We might have her, might really at this point encourage that open glottis pushing. But so you can even push with every third contraction. Sometimes that will help the baby sort of rest and recover. We also monitor maternal vital signs. So you might be checking them as often as every 5 to 15 minutes. I usually check them about every 15 during this point in labor. And of course, some people get really annoyed by that because they just, they have a job to do and they don't want to be interrupted for their blood pressure. But most people don't really mind as long as you catch them between contractions. You want to encourage laboring down if you can. If that mom is fully dilated but has no urge to push, she's really not going to push effectively, and you're going to be there for a long time, getting mom tired, watching baby get tired, and really not seeing as much progress as you'd hoped for, and that can make mom very discouraged. And when mom is discouraged, she might give up putting her best efforts in. Another thing that we can do for mom is positioning. Let's see if I can find some good pictures for you about second stage. Okay, so here's one. This is the use of the squat bar right there. Let me see if I can kind of point that out. You put these, there's like little holes down here, and then we thread the sheet through. I love this maneuver because it kind of saves your back. We used to let mom pull in our arms a lot. And when you're a young nurse and you're kind of strong, it doesn't bother you as much. But after, a couple dozen or 100 deliveries, it does start to play with your back a little bit. So using the squat bar is actually a whole lot better, and it's empowering to mom, and that she kind of feels like she can do this the right way. And if you see how this mom is positioned, she's positioned in a more upright position, and that gravity can sort of assist descent. Oh, let's get rid of that. See if I have another position for you. This is a side lying position. Okay, and this is like, I guess they're taking a childbirth class. But mom is on the side, and her partner kind of holds that leg up. And sometimes moms push in this position, and it helps, especially if the baby's posterior, to get that hard occiput off of her sacrum. And it also is a good position when baby's heart rates are a little less reassuring. They're not awful enough maybe to stop pushing and make a different decision, but you might want maximum oxygen flow to that baby, so side lying is a pretty good position for that. Most women give birth in like a semi-sitting position. I'm not sure if I have a picture of it. If I don't, I'll get one. Let's see, what's this one? Oh, this is a squatting position. Okay, hold on. Okay, and here we have the semi-sitting position, and usually what you would find is, right about here, one person would be holding this foot, and maybe the dad would be holding that foot. Usually the monitor's on this side of the room, so I'd be on this side. Right, I'd be holding that foot. Monitor's usually right about here. And the advantage is it helps you use a little bit of gravity, but at the same time, you can really open up that pelvic outlet. And a mom who has an epidural who can't maintain any other position can push very effectively like this. It's not quite that laying down, but sometimes if mom is sitting straight up, that baby just kind of gets caught up on the pubic bone. If we lay her back a little bit more and then really open up those the hips, we can sometimes get the pelvis to sort of open up a little bit and get the baby to kind of slip under the pubic bone, which is important. So let's see if I can get that out of here. Yep, I can. And these little marks too, I can get them. Okay, so that's another position. I'm going to get the squatting picture back. Here it is. Here's another use of that squat bar. And you can see mom, you can lower the foot of the bed so that mom has a little sort of shelf to rest on. It makes like a little chair, and then you kind of hold on to this squatting bar. There are two disadvantages to this. Most American women, for number one, the number one reason is that they don't have the leg muscles to really maintain this for 2 hours that it might take to push out a baby. And the other one is that it does put more pressure on the perineum, and you sometimes get a higher incidence of tearing. So if you have a second-time mom who has maybe a little stronger leg muscles, this isn't a bad position. But if you want the benefits of squatting and you can't really use that squatting bar for too long, you can have mom sort of hang over the side of the bed. Hold on, I'll get a picture of that too. Okay, so there's that picture, and this I've used a lot more than the squatting bar. The squatting bar sometimes just doesn't feel really stable to me, and I'm not even sure what the weight limit on it is. I have used it, and I do like it with the sheet, but sometimes for a woman who wants to squat, I really like to just elevate the head of the bed all the way and let her turn around and kneel. And to me, that gives her a little bit more resting space, so that it, when she's in between pushes, she can just sort of put her head down on that pillow and rest. But moms can push really well in this position. I've seen a few babies delivered this way. So that's another position that you can try. Okay, and the next two items I'm going to discuss together. Assessing progress is important. It's important to know that mom's pushing effectively. Mom can put a lot of effort in, and if she's pushing in her legs or in her face, but not really into those muscles that expel the baby, she's really just kind of wasting her effort and getting tired for no good reason. So you want to assess that she's pushing effectively and that baby is moving downward. And you want to encourage mom. It's really discouraging sometimes. You're talking about pushing out a baby maybe a distance of 3 to 4 inches if you start kind of up high. And if it takes you 2 to 3 hours to do that, it can get very discouraging. Somebody's going, oh yeah, that's great, baby's coming, and the baby isn't there yet. And they feel like they're putting a lot of effort in, and they're not necessarily done for a while. So you need to encourage mom, and that's one of the other reasons that I do like the philosophy of laboring down when possible. If you have somebody with a strong epidural and a very weak urge to push, they can get very, very frustrated and discouraged, and they stop believing you when you tell them that they're doing a great job and that the baby is coming. So you maybe have to educate mom that, yeah, this doesn't happen overnight. First babies don't come flying out most of the time. It takes a lot of work. It is a very, very long couple of inches, and that each push brings the baby a little bit closer. So you do want to encourage mom and let her know that, yes, this is normal. This is the way that labor is progressing, and it's okay. But so those are some of the things that you can do in second stage labor. The other reason that you want to continually assess mom's pushing progress, especially if she's a first timer, the provider isn't going to stay in the room with you and push for that whole 2 hours if this is a prime with an epidural. They're going to maybe, come in, talk to the patient, tell them what to expect, and then they leave. And you really have to be the one who knows when to call them back in. But most of the time, unless you have a very good midwife who is very hands-on, they don't stay in the room just for second stage until really the baby is like +3 or crowning. And you also want to let certain other people know. If you want the nursery to be at your delivery, you're going to need to let them know that mom is ready for them. Now, mom could be pushing for a long time, like I said. So you don't want to call people in too early because they're standing around with nothing to do. They kind of start to doubt your assessment there. But if you need NICU, a neonatologist and a NICU nurse at your delivery because there's meconium or because there was recent medication, you definitely want to give them a heads up in plenty of time. So those are some things you would do for second stage labor. Another thing that you can do during second stage labor is to really make sure that that room is ready. And this includes making sure that you have the table with all of the instruments. And when you go into clinical, you'll probably see some of that. The other thing you want to do is make sure that you have everything you need to resuscitate the baby. Now, 90% of babies will come out and with no encouragement at all, start crying, just basic stimulation of being dried off. They'll start crying right away. Well, 10% of babies will need a little, extra help, and about 1% of babies will need extensive help. So even if you're not anticipating a problem, you should be ready for one just in case. So when you go into clinical, see how they set up a warmer. You'll notice that there's a source of oxygen, there's a source of suction, you may have a laryngoscope, you may have a bulb syringe. There may be things that you need to resuscitate a baby who's not ready to breathe. But you want to have these things ready before you have a delivery because it's really not a good time to go running around for equipment when you have a baby who is apneic and doesn't have any tone. That's really the wrong time to go looking for the equipment you need. So make sure you have everything you need. When it gets close, when you start to see the baby crowning, the doctor will probably want you to adjust, take the foot off the bed, or they might want you to adjust the lights so you get real bright lights so that they can see what they're doing. So there are certain tasks that are delegated to the labor nurse during delivery, during second stage. Obviously, if you have a woman who's having a precipitous delivery, and this is something we can cover in labor at risk, you might be the one who does deliver the baby. And in that case, we'll kind of cover that during labor at risk. But that might be part of your job as a labor nurse as well. Okay, so now during the third stage of labor, the baby has just delivered and we're waiting on a placenta. There are still some things that the nurse is going to need to do. I mean, first you have a baby. So dry, stimulate, and if you have to, suction the infant. Now, we used to bulb suction everybody, every baby, thinking that it was absolutely necessary. And really the evidence suggests that you should only do that if you really need to clear the airway. But drying and stimulating a lot of times will just get that baby to cry, and that'll be enough to sort of clear the airways. Okay, so another task that you might be asked to do as a labor nurse during this third stage, at 1 minute of age and 5 minutes of age, you are going to need to calculate the APGAR score. Now, nursery might do this. If you have a neonatologist there, they might do the APGARs. But if you're there as a labor nurse and you're the one attending to the baby, especially if you're doing, the baby's great and you're doing skin to skin right away, you might be the one who's sort of there in the room observing the criteria. And the APGAR score is named after Virginia Apgar, who is an anesthesiologist. There are 5 categories by which we assess the neonatal transition to extrauterine life. And these 5 categories have scores that range from 0, 1, and 2. Okay, so it is possible to get a 1 or a 2 or a 0. And here's a copy of the APGAR system. And I guess we were lucky that Virginia APGAR's name was APGAR because it gives us a nice little acronym. The A stands for activity, which is our muscle tone. Now, muscle tone can be active, where the baby's moving, and that gets a 2. Now, if the arms and legs are flexed, that gets a 1. And if you have a floppy baby, like a flaccid baby, you have 0 for absent. Pulse, P, the P is for pulse. That's a heart rate. The heart rate that's greater than 100 beats per minute gets you a 2. If it's somewhere between 0 and 100, if you get a heartbeat of 40, you still get a 1. And if it's absent, you get 0. Now, that's not really what's guiding your resuscitation efforts. Just so you know, that's a whole separate thing that you're not going to learn about as first-year nursing students. You'll have to learn about that when you get a job in maternal newborn and you learn NRP, which is neonatal resuscitation. But greater than 100 beats per minute is considered reassuring. Any heart rate at all gives you 1 point, and an absent pulse gets you 0. Okay, so the G in APGAR is for grimace. And this is a baby who is actively pulling away from you. You're tickling his foot and he pulls it away. Or, you're trying to dry or suction. The baby, reacts pretty forcefully. Number 1 is a grimace. And that's where the baby sort of, gives you a weak response to stimulation. And 0 is no response. Maybe you're rubbing this baby's feet, or maybe you're rubbing the baby's back, or you're tapping the baby's feet vigorously and that baby's not responding. That would be a 0 for reflex irritability. The next A in APGAR is for appearance, and this is where we look at the skin color. Now, if you get a baby that is all pink, that is 2. If you get a baby that is all pink except for the hands and feet, which is known as acrocyanosis, that's pretty normal. You'll get a 1. And I would say, I'm going to say maybe 98% of babies. I don't have an exact number. I see very few that come out with pink hands and feet at 1 minute of age, or even 5 minutes of age. It usually takes an hour or so for those extremities to pink up. So they will get a 1 point, 1 point for that. 0 points if that baby is blue or pale all over. Okay. Now the last R, or the last letter in APGAR is R, and that's our respirations. Now if you have good lusty cry, a baby who's really crying away, that baby gets 2 points. If the baby has a weak that kind of a cry, that gets 1. And if your baby's not crying at all, it gets a 0. Now scores of 8, 9, and 10 are all considered very good scores. When you are at 6 and 7, that's a baby who needs help to sort of come around. And if it's really under 6, definitely you're looking at a very depressed baby, in terms of their response to extrauterine life. But that's the APGAR scale, and we're going to play with this a little bit in class. Now you can automatically give your baby at least a 9 if they are screaming vigorously and kicking. Because they really kind of made all of that. It's the babies that are sort of halfway. They sort of make this half-hearted response to being born that take a little extra time with the APGAR scale. And I can guarantee you APGAR scoring makes a great test question. So we're going to play with this a little bit. We'll probably get some pictures of babies. We'll get some, have some different descriptions. Maybe I'll even get some recorded cries and let you decide what the baby's APGARs are. But this would be something that either the labor nurse or the nursery nurse could do. Very often the labor nurses just do it. But APGAR scoring is done at 1 minute and 5 minutes of age. And if the 5-minute APGAR is 7 or less, you're probably going to do a 10-minute APGAR. And I have seen even up to 20-minute APGARs, a baby who is really, really slow to respond. We've had babies with 003 APGARs or 022 APGARs. Those are babies that go straight to NICU. They're just born so depressed. Okay, so those are some of the things you would do at the 3rd stage of labor. Some other tasks that you will be expected to do as the labor and delivery nurse during the third stage is to collect cord blood for the type and RH. Now, as soon as that cord is clamped and cut, the provider will probably ask you for a container to put the cord blood in, and you'll send that cord blood to the lab for analysis to get the baby's blood type and RH. If parents are doing cord blood collection, at that point, you would hand the provider the equipment. They would be responsible for collecting it. There's like a needle on the end of some tubing that's connected to a bag, and they collect the cord blood for stem cell collection. So if you see that the parents are doing cord blood for stem cell collection, you would assist the physician with that. Now, administration of oxytocin during third stage of labor. When I started in labor, we really always waited until the placenta was out to start our Pitocin. Now the trend is more, the evidence-based practice is more towards doing the Pitocin as a pre-placenta administration. And we bolus, pretty big amount of Pitocin, especially when you're talking about we start the pump at like 1 ml per hour. Then we kind of jack it up to 334 milliliters per hour in third stage. Some providers still want you to wait until the placenta is out. So if I'm standing there, they check it off on their orders, but I don't always go out to a computer and check the orders. I'll just ask them, are you pre-placenta or post-placenta? And if I know them well enough that I've worked with them before, I might already anticipate what they want. But a lot of providers now are doing that oxytocin before the placenta comes out, and it does seem to shorten the length of the third stage of labor, so that's always good to know. Other things that you will do during third stage of labor, you're going to observe for signs of placental separation. Of course, the provider is still there. And you document when that placenta, as the nurse, you're going to be the one paying attention to the clock to see when that placenta comes out. And of course, if there's any delay in getting the placenta out, you are going to be ready to give certain medications because a retained placenta can cause a lot of bleeding. So sorry, I'm just writing this down for you so you have it. And the number one that I know of is Cytotec, also known as misoprostol. It's the same drug, just misoprostol is the generic name. And that is a prostaglandin that we use. There's some kind of midwifey ways to get the placenta going. If you keep the baby skin to skin and you encourage breastfeeding, sometimes that natural release of oxytocin will help get the placenta out. Something else you might do, you might, because a lot of times you're the one really caring for that couplet, initiate skin-to-skin contact. And you're also going to identify, in most hospitals there's a bracelet system. There's like a security system. You have these ID bracelets, and you place them on mom and dad right at delivery, and the baby gets one, and all the numbers are sort of pre-printed on them, and they all match. Sorry, that's like right in the worst spot. Okay, and that way there's no confusion about whether this was the baby that belonged with the parents. Of course, if we're minimizing separation, it's a lot less likely to have any kind of mix-up, but we have to have some system that makes sure that our baby ends up with the right parents. It sounds like, it would be kind of a no-brainer, but really, if you're doing a lot of deliveries, you need to have a system to make sure that that happens. So these are all things that can happen during the third stage of labor. And obviously, if you have any problem with mom or with baby, you have to be ready to intervene in an emergency. And those things are kind of covered more under labor at risk. And now we're going to finish up with the care of the woman during the fourth stage of labor, which, if you remember, is the recovery. Now, for the first hour after delivery, or even the first 2 hours, this is when mom is at the greatest danger of postpartum hemorrhage. So we're going to assess her vital signs, her bleeding, also known as her lochia, and her fundal height and consistency at least every 15 minutes. Okay? And that's going to be really, really, really important. Okay? Mom now feels like her job is over, and now she's ready to enjoy her baby. Her family's there to visit her. A lot of things start to take precedence for her. Remember, birth is a family event. So now she doesn't anymore see that this is a medical sort of event. But this is really when mom is in the most danger of having a postpartum hemorrhage. So we're going to assess those things. We also want to take a look at her bottom. We might apply ice to prevent swelling. And you're also going to look and make sure that there's no great big trickle. And here's what's like too much. A steady trickle usually tells you there's something bleeding. It might not be uterine bleeding. It could be from a laceration. But you want to make sure that that's not really what's happening. If mom has giant clots, you're going to have to express them. That means pushing down on the fundus a little bit. And you're going to have to assess her bladder, okay, periodically. But these are all things that you want to do. Instruct the mom not to get out of bed without assistance. Especially if she's had an epidural. Moms can get very faint and pass out, even when they've had an unmedicated birth. But the mom who's had an epidural is definitely at risk. If they have decreased sensation in their legs and decreased movement and decreased muscle strength, you might get that mom out of bed and her legs buckle right underneath her, and then you've got mom on the floor, and that's sort of an embarrassing situation to put yourself in. So make sure that mom knows that she needs to stay in bed and call for assistance, and make sure that before you get her out of bed for the first time that you're testing her muscle strength and you're making sure that her vitals are stable and that her bleeding is stable. You're also going to assist with skin to skin if you haven't done that already. And you're going to assist with positioning and latching the baby that's breastfeeding. Now, this is a great time to do a lot of education with mom, but be careful that you don't overload her. You're going to learn in postpartum, which is, I believe, Unit 11, all about these different phases that mom goes through. And the first phase she goes through is this taking in phase. And the book describes it as this period where mom is all about her. You know, there's a self-centeredness or self-absorption involved here. And it really, having seen this so many times, the taking in phase is really about, oh, wow, what just happened to me? Mom has had this profound event just happen in her body and in her life, and she sort of has to take a little bit of time to process it. It's not that she's narcissistic or self-centered so much as she just can't focus on anything except what just happened to her. And so, yeah, we do a lot of teaching. We teach mom about hunger cues, and we teach mom about taking care of herself and fundal massage and comfort measures for her bottom. Just be careful. And you may have to repeat your teaching, or you may have to pass that on to the next nurse. You're going to transfer her up to postpartum, hopefully, and someone else will take care of this. But mom may need a lot of repeated education. Just make sure that you start the ball rolling and that you're assisting her with all of these important tasks. So that's basically the care of the woman during the intrapartum phase, 4th stage. Also, I'll just throw this in here as pain relief. And I need a place to put that, so let me just kind of clean up what I've got here. Okay, so pain relief. She might need Motrin or something stronger, or something topical for perineal pain or cramping or whatever it is she has. And one thing that I would like to call your attention to is that immediately after, we're talking about the fundal height, immediately after the delivery of the baby, the uterus clamps down and it sort of gets this globular shape right before it expels the placenta. As soon as the placenta is out, you're going to find that most of the time the fundus is at the level of the umbilicus. It should be firm, and it should be, pretty well contracted. And I know you guys had a lab where we asked you to bring in an orange or grapefruit or some kind of fruit that had that firm consistency to it. And some of you may have been in the clinical setting and you've assessed a fundus and you felt that shape and that firmness. So that would be what you would expect. Now, if that fundus feels more sort of squishy, spongy, not firm, that's called a boggy uterus, and we need to massage that and make sure that we get all the clots out and all the blood out and sort of irritate that uterus enough to get it to clamp down and keep the mom from bleeding. If it feels like it is above the level of the umbilicus and maybe deviated to the right, generally what that is from a bladder that hasn't been completely emptied, that's pushing the fundus or pushing the uterus out of its spot, and it's sort of preventing that uterus from contracting effectively. And that can cause a pretty big bleeding problem if we don't address it. So your intervention in that case would be to do a straight catheter, empty the bladder, and then assess the fundus again. And if you need to, you massage. If massage doesn't work and emptying the bladder doesn't work, and you're going to learn more about this in Unit 11, I think, and we'll talk about postpartum at risk, and I believe that Dr. Batesel is covering that content. But your intervention at that point might have to step up a little, and you might need some medications. You might need to open up your Pitocin a little bit wider and give mom a bolus. If she doesn't have an IV solution, infusion of oxytocin, you might have to give it to her IM or intramuscular. You might have to give Methergin. Methergin is a medication. It's an ergot derivative, also called methylorgonavine. You would take a blood pressure. If mom's hypertensive, you can't give it, but if not, you would go ahead, and the usual dose for that would be like 0.2 milligrams. So you could give the Methergin, and that's a vasoconstrictor. That would help mom to stop bleeding, and if that is not effective, or if you can't use it, you would go to a drug called carboprost or Hemabate. And this will all be repeated for you again in your postpartum content, but just so that you're aware that this might be something that you as a labor and delivery nurse in that first hour, in that 4th stage, might have to be responsible for. Now, Hemabate is a prostaglandin. It's a very powerful medication that can be used to stop a postpartum hemorrhage. The side effect of carboprost is, unfortunately, you get really bad diarrhea and mom doesn't even know she's having it, so you're changing the linens a little bit, and of course she's got her 20,000 closest friends in the room who all want to see the baby, and then that happens. But hopefully if she's hemorrhaging that badly, you've got visitor control. But so those might be some things that you're expected to do during 4th stage of labor. And that kind of concludes our content for this part of the unit. We're going to pick up again with medical interventions. We're going to talk about labor inductions and medications that we use. And we'll review all those postpartum hemorrhage medications again. It doesn't hurt to hear them more than once. And we'll talk about certain things like amniotomy, just to, familiarize you with that before we move on to things like labor at risk. And with labor at risk, we'll talk about meconium, we'll talk about shoulder dystocia, we'll talk about precipitous delivery, we'll talk about prolonged labor, all of those things that can put the labor process, the mom and baby will be at increased risk. for a poor outcome.